We're going to talk now about the power of pharmacogenomics, and I'm happy to introduce Serena Mitaly. Serena is the system clinical pharmacogenomics PharmD at Ochsner Health, and she really runs our pharmacogenomics program on a day-to-day basis. She completed a residency in pharmacogenomics at Mayo Clinic and a residency at the MedStar Washington Hospital as well. I'm happy to welcome her to the stage.
All right, well, thank you so much for that kind introduction, Dr. Matrana, and thank you again to everyone attending CAGLA. We were here last year as well, talking a bit more generally about our pharmacogenomics program at Ochsner, all the things that we offer through our program. And today, I really want to spend my time talking specifically about DPYD. And so, without further ado, we shall begin. So I have no financial disclosures to report from my presentation. And really what I would like us to take away from this presentation today, one is what is the role of DPYD? What is it? Why does it matter? What are we testing for? And what is the background of the different medications that are affected by DPYD? From there, I really want to talk about all of the different data that we have that supports why we need to be pre-testing for DPYD. So there's a multitude of studies showing how toxicities can be severe and sometimes fatal in patients when we are not testing for DPYD and we don't know this information. And then using all of that, coming together and looking at the various clinical guidelines that we have published, which again will recommend appropriate dose reductions, and then why that is so important clinically. So this is just a brief table of abbreviations. As we all know in the genetic world, I lovingly call the things we look at alphabet soup. There's a lot of just different numbers and letters. So this is here for reference as we'll be talking about various different organizations, enzymes, whatnot. So this is just here for reference. So the role of fluoropyrimidines within oncology. So as I'm sure we know, this is a very commonly used chemotherapy medication. We use it for a variety of different solid tumor treatments, predominantly colorectal, but we'll see it used in breast as well as head and neck cancers. In terms of colorectal cancer, it accounts for one of the largest, types of cancers that we see. We see around 4.5 million deaths per year. So this is a highly impactful cancer that has severe negative outcomes in many cases. And in terms of treatment for these cancers, fluoropyrimidines are used almost half the time. They're kind of the backbone in many of our traditional chemotherapy regimens. And it's typical for patients when treated with these fluoropyrimidines to develop toxicity. So we can see them in around 10 to 40% of patients, and this is without the use of pretesting. And the toxicities that we see, again, kind of on this list, but we see things like neutropenias, we see severe nausea, vomiting, diarrhea, kind of a hallmark, stomatitis, mucositis, and hand-foot syndrome as well. So a little bit of background on the DPYD gene itself. So DPYD is the gene that codes for the enzyme which we care about. So the DPD enzyme is responsible for breaking down our fluoropyrimidines. It's responsible for about 80% of the metabolism of these medications. So if a patient carries a DNA change that affects how much of that DPD enzyme they're able to produce, if patients aren't producing the enzyme required to break down the chemo, you're going to see more of that chemotherapy in their system. And when patients have higher levels of chemotherapy than we expect, their metabolism is shunted from this normal pathway where we get degradation and more towards these active metabolites. And when we have too many of these active metabolites in the bloodstream, this is what leads to the severe toxicities that we see in patients who have DPD deficiency. And we'll talk a little bit more about what the specific variations that we look for in the DPD gene are, but just knowing that in a global population, we see anywhere between 3 to 8% of patients will carry one of these variants that will increase the risk of developing a severe toxicity when treated with fluoropyrimidines. So here's the table that looks at all of the different variants that are currently known to have an effect on the DPD gene. Would be remiss to not talk about DPYD a bit more. So it's a very complex gene. There's almost 1,600 different variants that have been identified and reported out. But of these, there are 7 variants that we know of that we have data to support really affect the amount of DPD enzyme. And so this table was actually put together by the Association for Molecular Pathology Clinical Practice Committee's Pharmacogenomics Working Group, which is a mouthful, but they are a collaboration between our pharmacogenomics guideline groups as well as a pathology group. And what they do is they are evaluating all of the different reported variants. They look at which ones actually have an impact on function, and they provide these, they call tier recommendations. So all of the variants we see here in the chart are considered tier 1 recommendations. And for a tier 1 recommendation, this is the variants that they are saying labs need to be including on their panels because they have a substantial effect on the DPD enzyme activity, and they are seen in populations of at least a couple percent. So we actually see them within populations. So just some terminology when we start to look at the studies evaluating DPD deficiency, patients can either be heterozygous or homozygous. For a heterozygous, a patient will carry one of these alleles, and for a homozygous, they'll carry two of these alleles. We don't typically see patients who are homozygous. It's very rare. We see maybe 0.2% of populations. But again, within the heterozygotes, we do see between 3 to 5 or 3 to 8% depending on ancestry group. And so our two main variants shown at the top, we know that when patients carry these, they're likely to have little to no function at all of the DPD gene. And for these other variants, we see that patients may still retain some function of that enzyme, but it is markedly reduced as compared to a wild type variant. So going into our study review, this first study was done back in 2013, and what this study did is it really established how much more we see severe toxicities in patients who carry these two DPD enzyme variant carriers. So the first two that we really were able to look at were STAR2A, and I'm not going to say it, but this variant here. And so this was a meta-analysis, so it looked at a lot of existing studies, again, predominantly in European populations. And these patients all had solid tumors, and they were receiving a fluoropyrimidine-based chemotherapy. Now, all of these older studies are going to look at, this is before patients are dose reduced. So when we treat patients who have DPD deficiency with a standard dose, what are we seeing in terms of grade 3 severe toxicities? And so as we can see, overall toxicities, we see about a 5-time greater risk if you have DPD deficiency or you carry one of these genes. And we see similar risks when we look at various different toxicities. So within hematological, GI, mucositis, again, we see these substantially higher rates in patients who carry the DPD variants. So our next study, very similar. Really just want to include it to show that there is a lot of data out there looking at patients developing severe toxicities when they carry DPD variants. So this one, again, similar, also a meta-analysis. It did include a few more population groups than our last study, so we now have some Australian and North American populations, same demographics, patients receiving fluoropyrimidines. And again, without a dose reduction, we see these things, these odd ratios, these statistics of toxicities with both fluorouracil and capecitabine, whether it's an oral agent, an infused, or a bolus. Across the board, we see significantly higher toxicities, up to 5 to even 12 times in some cases. And then again, this is looking at our other key variants. And again, very similar, up to 9 times increased risk, 3 times, 1 time. So there is so much data showing that if we treat these patients with full doses, they are going to have severe toxicities in many cases. So this last study really talking about the toxicities associated with DPD variants, another meta-analysis, and really what this one is adding to our body of literature is now instead of only looking at 2 variants, we're including 2 more of those variants that we discussed in the beginning. And as we can see across the board, again, statistically significant, clinically significant increased risk of developing severe toxicities when patients carry these variants and they're not dose reduced. And these studies also, they look at overall as well as specific types of toxicities. So I think really what is astounding here when we look at the STAR 13, which similar to STAR 2A, this is coding for little to no activity of DPD at all. And when patients carry this, their hematological toxicity risk is almost 10 times higher, 10 times higher. And we can prevent this with, and we'll talk about the studies in our next few slides, but when we dose reduce, we can reduce this. It's possible, and there's a lot of data showing it. So here is our first kind of study really talking about what happens when we dose reduce these patients who we know carry DPD variants. So this study was done in 2016. It's a prospective study. And so they had around 1,600 patients, again, similar demographics. But now what we're seeing is if patients carried the STAR 2A variant, they received a 50% upfront reduction in their fluoropyrimidine therapy. And so this study, we see it kind of everywhere as the hallmark of DPD testing because the results are honestly astounding. When we look at overall grade 3 toxicity, we see a reduction from 73% compared to historical cohorts of patients who are not dose reduced, down to 28% when we're dose reducing that dose by half. They also looked at drug-induced deaths, so this was previously 10%, now down to none from this study. And we see similar incidences of toxicities of our standard dose patients, so we test them, see their wild type, giving a full dose, versus the toxicities we see when we give our DPD deficient patients the 50% dose reduction. So we are greatly improving from what we were doing before, and we're moving towards the normal standard of care toxicities we see with our standard doses. The study also took a look at treatment cost. Again, maybe not quite as applicable to here. This was done in the Netherlands, so they're looking at euros, and as we know, their health system works a little bit differently than it does here in the States, but they did show that in total treatment cost, it was lower for patients who they screened for DPD versus those who they did not. So there is cost benefit as well. So our next study is also looking at dose reductions. And in this study, they expanded. So previously, we were only looking at one variant, the STAR 2A. But we know there are 7 significant variants. So this was the first study to look at more than just the 2A variants. Again, very similar study design. What's a little bit different about this study is that they used either a 25% or a 50% reduction, depending on which variant the patient carried. So for the STAR 2A and another variant, they used 50%, but for 2 of those that instead of a full reduction of function, they have just some reduction of function, they chose to do a 25% dose reduction to kind of match what they expect the patient's DPD enzyme activity to be. And so when we first look at these results, they seem surprising, right? Why are we seeing now when we're dose reducing patients, we're seeing somewhat of a higher toxicity overall? So when we look more closely into the data, when we look at STAR 2A and STAR 13, we see results that we would expect, right? We're dose reducing, we're seeing better toxicities with the 50% reduction in both of these cases. When we look at our other 2 that are not a full enzyme reduction but a partial, we see when compared to historical cohorts, we're doing better. We're seeing less toxicities by decreasing the doses, but we're not seeing as much of a decrease as we would expect. And this is likely because these patients needed a more dose reduction. 25% likely wasn't enough to really fully prevent the toxicities from occurring. And we'll talk about this a bit more in our upcoming studies, but really one of the hallmarks when we talk about DPD dosing is what is the best upfront dose reduction and when are we going to increase the dose for efficacy and toxicity? And another thing I wanted to highlight about this study, this was a secondary finding, but they did not see any significant changes between their wild types and variants in terms of hospital admits, how long patients were in the hospital for, or if patients withdrew due to toxicity. So they didn't see significant differences in those variables. And so this is our clinical guideline recommendations from CPIC. For those of us who aren't familiar, they are the Clinical Pharmacogenetics Working Group Consortium. They work on putting together freely available, peer-reviewed, evidence-based, and detailed clinical practice guidelines for various gene-drug pairs within pharmacogenomics. I would also like to note that other countries use other guideline bodies, and they have recommendations for dose reductions as well. So in both the Spanish and the French recommendations, they are recommending pre-screening for all patients, and they are recommending a 50% reduction or avoidance regardless of activity scores or what the variant that patient has is. In terms of the Italian guidelines, they're also very similar, but they are a little bit more specific in their dose adjustment based on the specific variant that a patient is carrying. And so I put here in our box our CPIC guideline recommendations. So activity score of 1 is essentially if a patient has 1 normal and 1 of those that has the full reduction. So their overall expected activity of the DPD enzyme is 50%. So, they're recommending that dose reduction of 50% congruent with our studies. When we get into an activity score of 1.5, which is the patients we looked at previously, it gets a little more gray, and they can say, you can do anywhere between 25 to 50%, noting that for some of those patients, they likely will need the full 50% reduction, whereas others may be okay with the 25. And for one of these specific variants, there is a lot of mixed data, and again, we'll talk a bit more about it as we go through our presentation, but we see patients who carry this. Some of them have more activity than we'd expect, some have less, and that's why it's something that we continue to study in our clinical research. So our next study, this is the first study that is really starting to look at efficacy. So as we talked about, we have so many studies that show increased risk of toxicity. So we have folks come back and we say, well, are patients still getting the best treatment out of their cancer? Is their overall survival unaffected by these dose reductions? Are we still seeing good progression-free survival? So this study here by Henriks et al., this was a matched pair analysis. So this one took patients who were STAR2A carriers and matched them to wild-type patients who had similar baseline demographics. And when they looked at these, there were about 37 patients that were able to successfully match. And what they found is that the overall survival and progression-free survival were not negatively impacted by the 50% dose reduction, and this was found to be statistically significant. And so they also took a look at the toxicities as well as our efficacy outcomes. And so we can see when we dose reduce our STAR2A carriers versus just our standard wild types, the overall toxicity is mainly unchanged, which is significant across the board. And then again, like what we saw earlier, when we compare patients who are dose reduced versus those who are not, we see huge changes in their overall toxicity, 18% versus 77%. And if me as a clinician, I know if I'm not testing and, maybe 5% of my patients could potentially carry this variant, and I know if I give them the full dose, there's a 77% chance that they can have a grade 3 severe toxicity, why would I not do the test to prevent that? And so this is the last kind of study that I want us to talk about today. This one was by Nickman et al., and this was a retrospective match pair analysis. They actually looked back at the study done by Henriks et al. In 2018, which was that first study that showed the dose reductions in our DPD carriers for the 4 different variants. So they did either a 25% or 50% dose reduction in those cases. And what this study aimed to do is it wanted to look at both progression-free survival and overall survival for these different carriers of the DPD variants when treated with reduced doses. So in total, they had 931 patients who were receiving these regimens. I know it's a bit small here on the screen, but we can see out of these patients, 279 were wild types, 93 being variants. There are 25 patients in the STAR2A group, only 13 in one group, and then our last group of, I call it our problem child variant, was the highest at 61 patients. So there's a lot to kind of digest and go through in terms of this study. And when I first look at the results of this, the first thing I take a look at is overall, what was the impact on overall survival and progression-free survival? So we can see here the difference in medians of months. There is some slight difference, but it was not found to be statistically significant overall for all of our DPD variants that we tested for. There is one, again, I lovingly call it the problem child variant. If you see the C1236G to A, where we do see a slightly higher reduced progression-free survival and overall survival. And again, this is just looking at the data in a different way. So they did a Cox regression match survival, and we can see, again, with our variant carriers overall, not seeing a significant difference between the two. But when we look at our problem child, we do see a slight difference here. And again, some of the reasons the study quotes for this is inherently when we look at levels of fluoropyrimidines in patients with this variant, there's a lot of variance in how much enzyme activity these patients will have. Another really big thing to consider is that in the original protocol from the study this study was referencing or looking at, they put in their protocol that if patients tolerated doses, they should have dose modifications, meaning if a patient tolerated it, you should go up on the dose per tolerance. And in this study, in 75.8% of patients with this variant, those doses were not modified appropriately. So there's many reasons why this may or may not have occurred, but per protocol, if patients tolerated, they should have gone up on the dose, and they did not. So they theorized that this could have potentially affected the progression-free survival and overall survival. And another, last thing to know is that, well, yes, we do see some of these changes in this one group. They also had more toxicities. So you're not seeing a benefit in either in this case. And really what this tells us as clinicians is that for this variant particularly, we simply need more information on exactly how to best dose reduce these patients. And so after this study was published, the Nick et al. That we just reviewed, our guidelines, CPIC actually kind of, based on this data, put together some responses to this study. The first thing they pointed out is that it's called the HAP-B3, and that's, again, lovingly our problem child, the 123G6A. They found that this test may not always be accurate. And the reason for this is that this variant is associated with a different change in the DNA that is truly responsible for the reduction in activity, or that's what we thought. A study came out that showed there are patients who will have just the 1236GA without links to the causative enzyme change. So what this means is that if a test is only looking at this and not the true causative SNP change, it could come back saying a patient has a variant when in reality they may actually not. So our guidelines, say that we should clearly state that this was inferred by the causal SNP, and if it's not present, interpret carefully because this patient may not truly have a DPD deficiency. Another statement that the CPIC guidelines put out based on this study is, again, kind of what I discussed. While we did see some of those changes, we also saw a lot of increased toxicity, and the majority of patients who received this dose reduction were not dose escalated, which is recommended in the CPIC guidelines. And so they didn't make any specific changes to the guideline, but really focusing clinicians to be focused on dose titration. So if you're reducing someone, they tolerate it well, it's okay to go up to an effective dose and test for toxicity. And again, I really just wanted to go back to our guidelines to drive home the point that if you know a patient likely carries a variant that's going to reduce their ability to process chemotherapy, reduce it. If they're safe, check carefully and go back up on the dose to get to effective treatment, and that is what our guidelines currently recommend. And I don't have it here in the slides, but within the Dutch guidelines, they actually do provide some data and insight in real life practice and how much and how often are we seeing dose titrations in our patients who have DPYD variants. So they found that with intermediate metabolizers who have an activity score of 1, they see an average dose titration is up to 57% of standard dose out of 17 patients. So in true practice, they're getting that 50% reduction, and then on average, they're going up a little bit based on tolerance. Interestingly, with intermediate metabolizers with that activity score of 1.5, for our problem child variant, they found that when doses are titrated up, on average, they go up to about a 74% titration, and in other cases, a 64% titration with other variants that are reduced function. And so in summary, there's a lot of really strong clinical evidence to support that when patients have DPD variants and they are treated with high doses or standard doses of fluoropyrimidines, they are going to be at a severely increased rate of developing severe toxicities. We also have strong evidence to show that when we reduce the dose of fluoropyrimidines in these same patients, it improves their safety outcomes similar to standard of care treatment. So our wild type carriers getting full standard doses, we see very similar toxicity. So with dose reducing, these patients who were previously thought to be high risk are now going to be standard risk. There's emerging clinical evidence to support that dose reductions in fluoropyrimidines do not negatively affect progression-free and overall survival. And for certain variants that may be associated with those, it's really important to do early dose titrations based on toxicities as well as therapeutic drug monitoring so that we can get those patients to an effective dose. These are my references. That's all I had for today, and I'm happy to answer any questions you all may have. Thank you so much.